Dear experts and fellows, good morning. We are going to perform a microwave ablation of submucosal fibroids today. Good morning. Here is the case description of the patient. This is a case of percutaneous microwave ablation treatment for uterine submucosal fibroids. The patient is 39 years old, married, age 8 A uterine fibroid was found on physical examination 6 years ago, in 2014. The fibroid was less than 1 centimeter in diameter and did not cause obvious clinical symptoms. The patient then reviewed regularly and found that the size of fibroid was gradually increased. She had menorrhagia 2 years ago. Recently her period has been extended from 7 to 8 days to 12 to 13 days, and HB was 80 grams per liter at its lowest. After ultrasonography, it showed that the fibroid was significantly enlarged to 7.3 centimeters, 5.7 centimeters. Anemia had been remarkably improved by treated with iron therapy. Pelvic MRI and ultrasound were performed in November 2019, and results showed that the size of the fibroid was 10.5 8.4 8.8 centimeters, located in the posterior wall of the uterus, and 50% of it bulged into the uterine cavity. The patient refused to undergo resection of the fibroid, and the gynecology department administered leuprolide 6 times in a row, once every 4 weeks, resulting in pharmacological menopause. However, the patient still had irregular vaginal bleeding during medication. It was bright red with blood clots, and blood routine test showed mild anemia. On March 26, 2020, she had pelvic MRI and ultrasound in our hospital again, and the result indicated that the size of the fibroid was 7.7 6.5 7.1 centimeters, and 50% of it bulged into the uterine cavity. This is the result of prolonged treatment with leuprolide, but leuprolide has definite ovarian suppressive properties and can cause permanent menopause if used for a long time, which is not appropriate for a 39-year-old patient. Here are MRI images of the patient before the injection of leuprolide. The arrow points to the uterine fibroid, and the triangle points to endometrium. We could see that the endometrium has displaced. Rich blood supply was observed in the fibroid from the enhanced images. After 6 times injection of leuprolide, the fibroid shrank obviously, but blood supply was still rich. Due to prolonged injection of leuprolide, endometrium is markedly thinned, and it is not easy to identify clearly on such static images. Ultrasound showed rich blood supply in the fibroid as well. Endometrium could be identified and measured by dynamic imaging, and it is 2 to 3 millimeters. A routine examination was performed after admission. Blood routine test results showed HB was 99 grams per liter, mild anemia. The result of sex hormone testing, 6 items, were basically in the normal range. However, it should be clear that this patient is currently in a state of pharmacological menopause, similar to menopause, and that on this basis the patient's hormone levels are abnormal, such as estradiol and prolactin, which are also the result of some side effects of long-term treatment with leuprolide and endocrine disruption. Dr. Dong presented this patient's case, and we will look at the images of this patient's series of MRIs below. We can see from these images that her endometrium was relatively clear before the medication, about 8 to 9 millimeters thick, and because this patient was bleeding constantly. The gynecology department advised her to have an artificial amenorrhea to reduce the bleeding symptoms, and then recommended undergo surgery. By the time this patient came to us for ablation, she had already used it 6 times in a row. Let's take a look at the images of her after the medication. So her endometrium is very thin, and we measured only 2 millimeters on ultrasound, and 50 to 60% of the entire fibroid size is protruding into the uterine cavity. In this way, care must be taken not to damage the endometrium too much during the ablation process, resulting in uterine amenorrhea. His patient is relatively young and she actually has partial damage to her endometrium. She has no fertility requirements, so it is not a big problem. However, it must not cause complete damage to the endometrium. Let's go back to her last MRI and we'll look at her MRI enhanced images. This patient has a very rich blood supply, so before ablation, we have to read her MRI images carefully. One is to look at her T2, like the relationship between the endometrium and the fibroids. Then on the enhanced MRI we look at the blood supply, we see that the whole fibroid blood supply is very rich. Then when we do the ultrasound, we do the contrast enhanced ultrasonography, CEUS, and the color Doppler ultrasonography. One is to evaluate the state of blood supply inside the tumor, and the other is to dynamically observe the special blood supply part of the tumor in real time when we do ultrasound. In addition, we should pay attention to which artery is the thickest in her main tumor. In this way, when we place the ablation needle, we position the ablation needle closest to the vessel to create an embolization of the vessel as soon as possible. This allows to increase efficiency during the ablation process. Here we will see the complete ablation procedure. Before we do the ablation treatment, we have to be well prepared. First of all, we have to do an ultrasound scan of the pelvis to carefully determine the size and location of the whole fibroid and its relationship with the endometrium. We see that the whole fibroid is relatively hypoechoic, and now her endometrium is here in the hypoechoic part, and the endometrium is now very thin, only 2 millimeters as we measured before. Because this patient is still young, we put a contrast catheter in her uterine cavity before the procedure in order to prevent the endometrium from being injured during the ablation process, so that the endometrium can be clearly marked. Because her endometrium was so thin that it was no longer visible, in which case the endometrium showed up more clearly. Before the procedure, in addition to looking at her fibroid size and location, we should analyze exactly which type of fibroid she has according to the International Federation of Gynecology and Obstetrics (FIGO) classification, and then look at the blood flow status of the fibroid. When doing color ultrasound, we have to adjust the color blood flow scale appropriately so that both low and high velocity blood flow can be clearly displayed, and also to see the status of blood supply to this fibroid. This fibroid is very typical of the blood supply characteristic of uterine fibroids, which is a subserosal blood supply surrounding the entire fibroid. The blood supply to her fibroid is here, and when we do an ablation, we have to block the vasa vasorum. When we ablate, we have to pay attention to the pedicle of blood vessels that supply blood to the fibroid. It is in this place, not up there. Then we could observe its condition from the other side. Then measure the size of the tumor. The whole fibroid is 7.0, Tarankan 6.4, and recorded, and the third side is 7.2. We plan to ablate such a large tumor with 2 ablation antennas at the same time, using 60 watts. We need to look at the condition of the fibroid in the endometrium, in addition to the condition between the myometrium and the posterior wall. We also need to scan the patient's ovaries to see where they are located. These avoid injury to the ovary by passing the antennas through the ovary during ablation, or disturbance of the ovary by the thermal field during ablation. This is the left ovary, the right ovary is here, which has been smaller. Because she had been on hormonal medication, it suppressed her entire ovary, so her right ovary was smaller. Also, before treatment we have to insert gauze balls into the fornix to hold the uterus in place. This curved hyperecho is the gauze ball we inserted into the fornix earlier. We do a CEUS contrast enhanced ultrasound. The purpose of the CEUS contrast enhanced ultrasound is to evaluate the state of the blood supply. The image should be on file so that the ablation effect could be evaluated immediately after the procedure is done. Now the contrast has been injected, we routinely use 2.4 intravenous push. We see a very typical state of blood supply to the uterine fibroids, with gradual filling from the periphery to the interior, and a very typical state of a peripheral subserosal blood supply ring with some thick vessels inside. When we do the ablation, we will place the antennas directly in close proximity to the thicker vessels to improve the ablation efficiency. Okay, CEUS is over. We will now begin disinfection, surgical drape laying, local anesthesia, and preparation for ablation. Dr. Hart, start disinfection, please. We now prepare the disinfection, which is based on the size of the fibroid and the position of the uterus. The area to be disinfected should be large enough. Normally up to the navel. For some large fibroids or uterus adenomyosis, which protrude upward or toward to the uterine fundus, we have to disinfect even up to the NC sternum. Down to pubes. Left and right to anterior superior iliac spine. We routinely disinfect 3 times, with each disinfection spreading out in all directions from the center of the puncture. Okay, this is the 3rd disinfection. Then we lay the sterile treatment towel. Despite that this patient had been on difreeline triptolin for 6 months, her uterine fibroid blood supply was still very rich. Although both the MRI and ultrasound showed that this was a typical uterine fibroid. To prevent some unforeseen circumstances, we decide to do biopsy anyway. When biopsy is performed, we should share the same route for biopsy and ablation, in order to minimize the number of punctures. In addition, this patient's fibroid is on the posterior wall and her endometrium is close to the anterior wall of the uterus, so it is important to avoid penetrating the endometrium as much as possible when taking biopsies and inserting antennas. And to pay attention during the puncture biopsy to those with a particularly rich blood supply, endometrium in the front, or combined with adenomyosis. To prevent tract implantation or in case the lesion is malignant, coaxial needle biopsy is used. If the MRI ultrasound results show a highly suspected to be malignant, the patient is advised to have the myomectomy instead of ablation. The probe is covered with a sterile probe sleeve, and the puncture should be guided with a puncture-guided device. The fibroids are relatively hard, so that it is sometimes not easy for freehand puncture to perform accurately. We used an 18G biopsy needle for biopsy. However, this patient has an abundant blood supply to the fibroid, so to avoid bleeding during the biopsy puncture, we put an ablation antenna first. Check the angle of the guideline on the ultrasound equipment and the angle of the puncture-guided device. Both angles must match. We put an antenna in first and locally ablate it for a while, which will constrict the whole vessel and reduce the blood flow before performing the biopsy. We are doing a local anesthesia. Someone asked why we still need local anesthesia after general anesthesia. It helps to bulge the skin in order to reduce bleeding during puncture. We use the needle of a 50 ml syringe to make a small incision. Set 60W. The puncture path should be confirmed by repeated scanning to avoid the thick vessels of the large intestinal omentum in front. For this patient, we also need to avoid the endometrium. Move and check. Her endometrium is now here. Let's move and avoid it. Now there is no intestinal in front either. Let's confirm with color Doppler ultrasonography and avoid large blood vessels. We plan to insert needle into 11.5 and place it on the surface of serosa of the posterior wall of the uterine fibroid. Now we are ready to percutaneous puncture. $60W set and start. Local ablation is first performed using an antenna with 60W for 300, then do a biopsy. It is safer to do so and avoid bleeding. During the ablation process, the probe continuously scans the longitudinal and transverse sections so that we could observe the diffusion range of the thermal field. The thermal field should not go beyond the serosa. For submucosal fibroids like this, the goal of our treatment is to get the whole thing out. Therefore, the whole tumor should be ablated as much as possible, especially the blood supply area of the pedicle should be completely ablated, so that the whole tumor can flow out. $100 passed. We will ablate 300. Then we stop for biopsy. Now we can see the heat running down the blood vessels near the cervix. We will insert another antenna in this area later and ablate this blood vessel completely. The whole fibroid is 7 tarankan 6.8 tarankan 6.4 centimeters. So we plan to use 2 antennas and ablate the bottom of the fibroid first, then lift both antennas to ablate the anterior part. It means we will have 4 spherical coagulation zones. $200 passed and $100 to go. Now the round circle in front is the catheter in the uterine cavity, the large cavity on the left is the bladder, and inside is the bladder catheter. Next, let's do a biopsy. This is a coaxial biopsy needle with triangular tip and allows to take multiple biopsies in one puncture. Before the biopsy, we must confirm that we will not pass through the intestinal omentum and endometrium, and avoid the large blood vessels. Here is the first antenna. The biopsy will along the path of the second antenna, so we insert the coaxial needle in first, then take a biopsy. Next, rotate the probe a little bit, change the angle and take another biopsy from the other side. For this case, we take 2 biopsies in total. Along the path of the biopsy, the second MW antenna is then inserted. We are inserting the coaxial biopsy needle slowly and steadily. Please note that the coaxial needle tip must not pass through the serosa. In other words, it should not insert into the fibroid, just against the surface of the serosa, then take a biopsy. If the fibroid is likely to be malignant, it will go along the cannula and no track implantation occur. Check the tissue, very white. Then we will take another biopsy. The angle of the probe has changed. We are aiming at hypochoid part of the fibroid. These areas are usually soft and have a higher rate of local regional carcinomatous change if it occurs. Two biopsies are enough. We took one biopsy in the regular hypochoic area and another one in the area with extremely low echo, which seemed to be partially liquefied. Biopsy was taken close to this area, but not directly from the liquefied area, otherwise the sample will contain too much fluid and you may not get a satisfactory result. We are pulling back the trocar needle slowly. Along the path of biopsy, the second antenna is then inserted accurately. The second antenna is set at 60 W. Now both antennas are placed precisely in the predetermined position, then start the ablation. Benign fibroids are usually hard. You can feel it when puncturing. If it feels soft, you need to pay attention and take additional biopsy if necessary. This hardness of the fibroid is consistent with our diagnosis. When ablating, you should be careful about the anterior endometrium and uterine cavity. Because we placed a catheter, so the position of the uterine cavity can be clearly marked. It is more to the lower left, which is still far from the uterine cavity, so it is safe. Now we can see the cambered hypochoic area. It is the serosa of this fibroid. In this state, enough energy and time could achieve the ablation effect. Because the blood supply under the serosal membrane of this fibroids is very rich, we can see that the entire thermal field runs along the blood vessels during the ablation process. It outlines the shape of the entire fibroids. The entire fibroid's subserosal blood vessels are bright. When the thermal field reaches a certain level and the subserosal blood vessels are all occluded, we can no longer see the flow of thermal field. Now the right part is very good. Most of left part has not been ablated yet. The left part has just ablated 100 only, the right part has been ablated 300. We plan to ablate 2 times with 60 W, 600 each. Antenna #2, 200 passed. Antenna #1, 500 passed. This fibroid has a sufficient thickness of normal muscle tissue around the submucosa. It is about 1.5 centimeters anteriorly, a little thinner at the back, but at least 0.5 centimeters. So it is safe to have a certain distance between it and the pelvis. We did not inject artificial ascites. The next day after finishing the procedure, the whole fibroid will be significantly shrunk. In this way, she can stop the dye-free line in the next month. It can no longer be used because prolonged use can cause drug-induced amenorrhea and the function of the ovaries will be impaired. Antenna #1 is 600 and antenna #2 is 300. Opt stop antenna #1 and antenna #2 keep going. Now start to withdraw the antennas. The forceps are fixed during the withdraw process, so we can see how much has been moved back. You can also observe the markers on the antennas. Okay, back enough now. Now continue ablation for antenna 8. After moving antennas, you must reconfirm where the radiation points are. Do not place it outward too much and make sure thermal field will not exceed the predetermined range. We see that it exceeded a little bit, so let's move 0.5 centimeters inward. Antenna 2400. The tissue texture of uterine fibroids is different from liver and kidney. The antennas will move with the patient's breathing during the ablation, so you have to hold them in place. Antenna 1150. Stop antenna #1 and antenna #2 keep going. Antenna 2500. Move antenna #2 1.5 centimeters upward when 600 is up. This fibroid is a bit flat on the left and right. We could see that the top and bottom are well covered by the thermal field, except the left part. Later, we have to move it to the left a little bit. Doctor is moving the antenna within the fibroid. We first ablate the entire right part. Antenna #1 start. Antenna 2600. We are now moving antenna hash to 1.5 centimeters up. Set 60W for antenna 2. You could see the radiation point is on the edge of the hyperchoic area of the spherical zone we just ablated. Then those two spherical zones will overlap. Antenna hash 1 stopped after 300s. For such a large fibroid with rich blood supply, you should carefully observe the arcuate arteries of the uterus during ablation, and stop ablating when the thermal field runs along the arcuate artery too much. A part of the arcuate arteries will become the uterine and ovarian arteries for blood supply. We did not know the source of the ovarian blood supply arteries of the patient. 50% of patients' blood supply comes from the ovarian artery, and 50% of it comes from the branch of ovarian and uterine artery. For the former, the blood supply comes from the ovarian artery. If we damage the arcuate artery and uterine artery, ovaries will be injured after the ablation, resulting in premature ovarian failure. For the latter, the blood supply comes from the branch of ovarian and uterine artery. If we damage the uterine artery, the blood supply to the ovary is basically cut off, and the ovary will lose function. During the ablation process, we controlled quite well, and the thermal field has not been out of the serosa. The blood supply is exactly in the serosa. Now you can clearly see the outline of the entire uterus. The blood supply basically stopped at here, but there is a small artery runs down to the uterus. So we stop ablating for a while and restart when this artery constrict, in order to prevent the thermal field spread out too much. The thermal field has covered the top, middle, and bottom of this fibroid completely. The uncovered part on the left has also been significantly reduced, and the ablation is still going on. Antenna hash to keep going, and stop antenna 8. Antenna hash 2 stopped after 300s. The ovaries, uterine cavity, endometrium, and myometrium are fine and safe, not affected by the thermal field. Antenna hash 2200, keep going. The lower part of the fibroid has been ablated completely. Ablating another 40. Antenna 2300. Opt stop for a while. Now we will move the second antenna which we just inserted. During CEUS we found that there are two large vessels on the left, in this crescent-shaped hypochoic area. They separate from the uterine artery and feeds the fibroid, so we have to ablate them as well. Dr. Har is going to show the moving process within the fibroid. We are moving the antenna slowly from the right to the left, taking out a little bit but still in the serosa of the fibroid. When we could see the antenna clearly, move its handle to the right so that the tip will move to the left. Go up a bit to the nutrient artery and ablate it. This makes the fibroid easy to flow out. Now setting is 50W. Now antenna hash to change to 50W. You could see that doctor placed the antennas at the designated position at the beginning. However, the fibroid contracts with breathing and moves the antennas outward. So keep looking at where the tip is and adjust the position if it moves. This fibroid is quite large and will shrink in necros after ablation. We should ablate it as thoroughly as possible in order to decrease patient's pain when discharge necrotic tissue from the body. Otherwise, it will not shrink enough and will be stuck in the cervix, can make patient very pain. Antenna hash to 100, keep going. This is close to the endometrium in the uterine cavity. You have to know exactly where is the endometrium. The intrauterine balloon catheter is quite helpful for marking their position. They are now at the linear hypochoic area, and there is an annular hypochoic area in this place, which shows that it is still far away from the ablation zone. There is concern that the plastic catheter will be burned. It will not happen if you could keep a proper distance between the thermal field and the catheter. Please note that the puncture path should not pass through or close to the catheter, and keep the thermal field at least 1 centimeter away from the catheter. In this case, the patient has no requirement for childbirth. We still have to protect the endometrium so that her menstruation could return to normal, otherwise, the injured endometrium will cause uterine amenorrhea. The endometrium must be protected very well if patients who require to give birth after treatment. During the ablation, in order to protect the endometrium, we could inject some cold sterile saline into uterine cavity through the catheter. Start antenna #1 at 60 W for 100-200. Antenna #2, 300, still takes another 200. Antenna 1, 400. Pay attention to the bladder at all times because a full bladder will push uterus away and cause displacement, in this case, drain it by using a urinary catheter. Anesthesia can be stopped. We will stop injecting the anesthetic before the end of the operation. Because there's still time for the anesthetic metabolism, making use of the remaining time to increase efficiency, the patient will wake up more quickly. Antenna #1500 still takes another 100 till 600 in total. Antenna 2, 400. We use 60 W, 600 for 2 ablations. With the carbonization of the tissue by microwave ablation, the fibroid significantly shrank and smaller than it was before treatment. We can reconfirm this by CEUS later. Antenna #1 already 600 oct stop it. Ablation time is up. You could see that the entire fibroid has been covered by the thermal field, then we can stop ablating and getting ready for CEUS. It helps to evaluate the ablation result, and we could immediately perform supplementary ablation if there are any areas where the contrast agent perfusion is not obvious. Considering the possibility of tract implantation, we must minimize the number of punctures. We are now going to adjust the urinary catheter in the bladder to discharge the urine before the CEUS. We start recording while inject the contrast agent. The ablation results are very satisfactory. The entire uterine fibroid has been completely conformal ablated. Here is left, right, up, and down. The entire ablation is over. We can withdraw all antennas now. Dr. Har is slowly pulling both antennas out. We have just confirmed that we did not pass through the endometrium, therefore, we are not going to do the tract ablation as malignant tumors treatment. Considering low malignant potential, it is unnecessary to ablate the endometrium. Such large fibroid with thin myometrium and too close to the surrounding tissue, we will not do the tract ablation to prevent injury. Okay, treatment ends. The trauma is quite small, even though we inserted two antennas, there are only two tiny pinholes in the skin. It is accurate and minimally invasive. If it is adenomyosis, especially condition is very serious, with heavy menstrual bleeding, we still have to ablate part of endometrium. In this case, we have to do tract ablation to avoid the risk of implantation. Here are the immediate images of post-ablation. It shows the diameter of fibroid has shrunk obviously to 6.2 tarankan 5.0 tarankan 6.0. That's all. Thank you for watching.